Hi, everybody. This is Professor Pochlepek. I'm bringing to you nursing care of patients with musculoskeletal and connective tissue disorders, Chapter 46 from your medical surgical textbook. So we will bring back some of the things from last semester and some new things for this semester. Some learning outcomes. You want to be able to explain the pathophysiology, signs and symptoms, and complications of fractures. Plan nursing care for patients with splints, casts, traction, and external fixation. Describe the causes and prevention of osteomyelitis, and plan the nursing care for osteomyelitis. Plan your nursing care for a patient with a fractured hip. Plan the nursing care for a patient having a total joint replacement. And explain patient teaching for a patient with a lower extremity amputation and prosthetic. So here we're revisiting a few things, bone and soft tissue disorders. So we're going to go in depth a little bit on strains, sprains, dislocation, bursitis, and rotator cuff injuries. So again, a strain, plain and simple, this is going to be a soft tissue injury that occurs when a muscle or a tendon is excessively stretched. So think a strain. It could be, somebody could strain lifting something heavy, lifting a heavy box, not using the proper body mechanics. Same thing if you're transferring a patient. You might be using the proper body mechanics and the patient suddenly goes down and you go down with them. So, but to be careful at how we use our body mechanics and really try to keep our core strengthened. So a sprain, excessive stretching of those ligaments. I think of a lot of twisting, sports activities. This can happen, football, soccer, any type of sport. Exercise it can happen in. I've had a lot of patients get it from jogging. I've had a few patients in my past that got it from that. They hit like a pothole on the road and twist. Or a real significant fall. Again, think about it. Not every fall leads to an injury, but it can. And a sprain can happen. Somebody's walking. Think about the ice outdoors now. You're walking down your driveway and boom. You just twist a certain way and there you go. You got a sprained ankle. So here's a few pictures. Big things with the strain, it's just a really, really bad stretch. It can be caused by a trauma or an injury. As I said earlier, there's going to be with these things muscle spasms and weakness and pain and everything. There could be inflammation and, sometimes, you can't have the same muscle function that you had if you have a strain. Down below with the sprain, I think more of a twist. You can see the tear down in the left-hand corner of your screen, and you can see the twist to the right with the red arrow there. It's going to have a tear. It's going to be a tear, and it's, usually sports, recreational activities. Again, it can happen just from a simple fall, too. And it can be sprains, upper body, and lower body parts. But again, most common is an ankle. Again, with that can be pain, swelling, bruising you usually see with that, and just can't really move the joint. Many patients will come in. I've had some students in the past out at urgent cares, and I'll tell you that they'll get a patient and they'll be in there screaming like they broke their ankle. So, and you have to rule out a break, obviously, with an x-ray and things, but sometimes it can just be a really bad sprain. So then we've got dislocation that we'll discuss. And, this happens when those bones are forced out of the regular normal position, so out of alignment. It's usually caused, it can happen in traumas, falls, contact sports. I've seen it in motor vehicle accidents, or it can be by disease. And rheumatoid arthritis is one of the diseases, and we'll discuss that further later on in this chapter. Bursitis, those fluid-filled sacs, the bursa, they cushion those tendons during movement to prevent, friction and help that bone and tendon, everything, you want to be a well-oiled machine. There's several joints that have bursa, and I listed some here: shoulders, elbows, hips, knees, ankles, heels. When you get inflammation of the bursa, it's called bursitis. I've seen several patients with this, and this can be, severe arthritis, gout, really repetitive movements. You can even get it from sleeping on your side. That's when that compresses the shoulder bursa. So, big thing with that, you'll see a lot of patients complaining of pain and everything. So good health history is going to help you figure out what's going on with this patient. If they've got a history of arthritis, history of gout, what type of do they play sports? What type of work do they do? Do they work construction or things like that? A few examples. And here's some pictures that you can see up here. We've got the normal finger up in the left top corner, and then you've got your dislocated finger over there. You can see that bone is right out of alignment, plain and simple. It gets really a lot of swelling, be a lot of pain. And down below, they got the bursa of the elbow. You can see the inflammation in there. That bursa is just bursitis. So there you go. So some visuals. And then you have rotator cuff injuries. And I've had a lot of patients, my last job, that would come in and, from all the pain and limited movement, they couldn't even lift their arms over their head. So think of that patient that can't put their shirt on, themselves, and have real terrible range of motion and everything. They might get an elective surgery for that. And then you've got the patients with injuries. So it's a muscle contraction causing those tendons to really tighten up, and they can't really move or rotate that shoulder in all the directions they need to. That range of motion is just gone. And there's so many different injuries. Do they have a chronic impingement syndrome? And that's when the top of the tendon of the cuff and the bursa become impinged in a narrow space under that acromion bone. So, it's going to not just be something that happens really quickly, unless it's like this big injury that they've had, a trauma. But I've had a lot of patients with arthritis, and they really, it takes time. They've tried everything: physical therapy, pain management, and they get to the point where they have to have elective surgery because it's just so painful and they can't do their ADLs and have a good quality of life. So you can see my pictures here. You got on the left the rotator cuff tear. That looks pretty mean. And then over here, you can see the shoulder, how it's just pinched up at the top there. The layers, it doesn't look like it's, free range of motion and movement. So you want to remember RICE always: rest, ice, compress, and elevating. So rest to protect, ice to decrease pain, swelling, inflammation, compress with that elastic ACE bandage. You want to properly put that on and compress and keep that injury, keep it like, think of the leg they show in the picture here. You want to keep it, from swelling up and keep it, stabilized. Elevating affected areas if appropriate. Meaning, that it can be elevated and there's no restrictions or anything, because that elevation is going to help with inflammation, pain management, everything. So always be safe, body mechanics and using what the facilities require. Part of the, think of the rules in the facility. You always want to know, what do they have to help prevent injuries to your back and body. So things like, I just put a few examples. There's so many others. Draw sheets are a big thing. I know it's an extra piece of linen, but getting that draw sheet and having somebody help you bring a patient up in bed is going to be a lot better for your patient, because we're going to prevent shearing and everything, and we're going to help, staff and their back injuries. So you guys, as future nurses, you'll be helping your CNAs out, and this would be a moment you could educate your CNAs to, protect their backs. You get one back, you don't want to get an injury. Mechanical devices, right there is just your traditional lift. There's various names of them, and that's all electronic there. They get charged and everything, and those are done with 2 assist. In the picture, you notice they're just trialing it. Should always be 2 assist. Most policies, I can guarantee, will say 2 people. I know in home care things get different because people take care of patients at home, family members, but out at facilities, it's definitely 2 people in case something goes wrong. And for safety for the patient and yourself. You don't want to pull patients' arms. You don't want to, hurt a patient because they're very fragile. You want to be using things like the sheets and stuff. There's various types of, they've got inflatable transfer devices you can put under patients, and it helps you lift up patients, that can be really heavy, some of the bariatric patients. There's different lifts out there that help the patient stand up. And if they've got good upper body strength, it'll help with toileting and everything. I don't have all the pictures there, but there's just various lifts, know that, and just the safety of it. And get help from people. One thing you'll always hear from me, the patient can be, say, in bed of 1 assist, but if you need that help, they might be weak, they might be sick. It always can upgrade and get more help. Never downgrade. I know staffing can be sometimes an issue, but you always want to try to get help. It's for you and it's for your patient. So carpal tunnel syndrome. I have a really good picture coming up here. It's that median nerve compression. So look to your wrist and just think inside there, it's going to be swelling in that tunnel, the fingers, the hands, and the arm pain and numbness you're going to hear from your patient. And tingling is going to be something else. You want to relieve that inflammation and rest that wrist. I'm always going to say prevent, make sure, when people are, for example, typing, using their mouse, that, how they position that arm where the carpal tunnel area is there from the elbow down to that wrist, we're positioning properly. If they're leaving it upright and typing for hours and hours, I think of students, and I think of people that are secretaries, they're going to end up probably with carpal tunnel. So splinting can be helpful. In the first few stages of it, anti-inflammatories can be helpful. And then it can get to the point where they have injections and things you can try, but it can get to the point where the patient's going to need surgery. So it's about prevention, because once you get it, it's a lot of management, and it can get worse because obviously some people, they're in jobs where they're repetitively using, their hands and things. So prevention, and techniques to try to prevent. And here's my pictures here. You can see that median nerve, the incision that would be made. And what they're going to do in there is they're going to go in and they're going to release that ligament. So a surgeon's going to do that. It's usually a day surgery. And I've had a few friends of mine have this done that are secretaries and work in fields where they are constantly having to type and do stuff. And there's been a lot of success with the surgery. I've heard some people say that, there's still some numbness, but not as bad. It is it can be a long recovery. It can be, 4 to 6 weeks. It's going to depend patient to patient how they're doing. But when they make that slice and release that ligament, it will help, relieve a lot of the pain. But again, prevention. So fractures we get into, that's a break in a bone. Can be trauma. It can be from disease, pathological. It can, be open, which would be a break in the skin. When I think of open, I've had one time a good friend of mine fall down the stairs and the bone went right out of the skin. It was a really bad tib fib fracture. So a closed fracture, it doesn't break the skin. Again, that can still be a broken leg and everything. It just didn't go through the skin. But just think, infection can be a huge risk. Think of all the marrow and your bones sticking out there. Infection's a big risk. So types of fractures. So your book does a nice job and goes through these. And you can see all them in my picture here, and then I'll go on to the chart here. So you want to have an idea of these fractures because you're going to see them in charts. You've probably already started to see them in certain charts, and they make sense, the fractures here. So I'm going to go on to the next slide. So an avulsion, that's going to be the bone is torn away from the main bones while still attached to a ligament or a tendon. Comminuted bone is splintered or shattered into various numerous fragments. It often occurs in crushing injuries. A patient might have their hand run over by something. I think of a couple factory workers I've had, they've had their foot run over by heavy machinery and things. Impacted, the bone is forcibly pushed together. So think of it smashed right together, resulting in the bone being pushed into the bone. So, impacted. Let's think of our boxers out there. Boom, they do that KO and impacted fracture. Green stick fracture, the bone's bent and fractured on the outer arc of the bend. This is one that's commonly seen in children. They really heal quickly. Interarticular fracture, that involves a bone within a joint and displaced. Those bone pieces are out of the normal alignment. One or more pieces may be out of alignment. It's going to depend. And then your pathological, they also can call it neoplastic. This can be when the bone is very weak, either from pressure from a tumor. I think of my cancer patients. Or there's an actual tumor within that bone. So it just becomes a lot of pressure, pushes on the bone, and can splinter it and break it. It can really get that severe. Spiral fracture, just think of spiral, curves around the shaft of that bone, the fracture, longitudinal. Fracture occurs along the length of the bone, so think long, the length. Oblique occurs diagonally or at an oblique angle across the bone. Stress fractures of the cortex, this is, an incomplete fracture. I think of the back with stress fractures. Transverse, the bone is fractured horizontally. Depressed fracture, the bone is pushed inward. It's seen in skull and facial fractures. I think of traumas. Think of any of the traumas that can happen to the head, from a car accident to kids falling off their bike to a fall of an adult. It can come up with lots of examples. So, start to put these words together, because you guys are reading a lot of charts and things, and, you'll come across patients with fractures. When you read these x-rays, you'll have a better understanding. So signs and symptoms of fractures. Pain, the range of motion is not going to be the same. Limb rotation, their leg could be twisted. I've seen that with a lot of hip fractures. When I'm assessing a patient down on the ground, if I see that twist of the leg and that shortening, I know I've got myself a good hip fracture, unfortunately. Deformities, shortening of the limbs, as it says here, lots of inflammation and swelling. Bruising is going to happen. Obviously, it's not going to happen in 2 seconds once they fall, but you'll notice that bruising. I can tell you, a lot of patients I've taken care of out in long-term care, and even in acute care, I've seen that bruising that next day. Boom, it looks a lot worse sometimes than it is, and sometimes it is bad. So bruising's big. Diagnostic tests that would do. Here's a couple examples. Obviously, x-rays, CT scans. They might do more types of diagnostics, but these are a couple examples. Emergency treatment, splint as it lies. You can tell here, this looks like my hiker out hiking. We've got people there. They're splinting as that leg lies. They're not lifting it up, fixing it if it's twist or anything. Splint it the way it looks down on the ground. Obviously, I'm talking about, being out and about. You're not, the patient's not at the hospital. So we're out in the field at this point, and seek medical treatment. So obviously, as you, the nurse, say this happens, let's just say in the nursing home, you're going to keep the patient down on the ground. Because I'm going to tell you, everybody loves to come and try to, put pillows under the people, do this, do that. Of course, you want to support people, but the more moving you do to them, you could cause injuries. So you're going to be the team member that says, okay, everybody, let's keep this patient down, and 911's called, and we, keep that patient stable, because we don't want to cause any, permanent injuries or any increased pain or anything. Fracture management, obviously we want to get those bones back in alignment, back in position, back with the range of motion working, and have that patient get back to, moving. So immobilization is going to happen. Big things with, like you see this this splint here, putting it on properly, checking the skin. I'm going to tell you, it's a Q shift thing. Every shift, we should be checking the skin if we're out, say, in long-term care. If we're sending our patients home, checking that skin. Don't just leave that on and go back and see the doctor. We got to make sure that no skin breakdown happens or any infection. Big things. In the healing phases, you can see that clot's going to form up in A in the top there. The fibroblasts and osteoblasts, it's all the healing process. Those fibrocartilages and everything starts to form. It's all healing from within on. Now, start to think. Analyze a little bit here and think and apply. What if you got diabetic patients? Things are not going to always go plain and simple, but this here is just your normal phases. So, but I want you to think a little bit beyond the normal sometimes. Think of patients with other illnesses and things, how are they going to heal? But you can see it goes on. You got the new bone is forming. It's repairing and completing and healing and remodeling and continuing to, an intact bone. It's just going to take a period of time, several weeks. Again, depending on the patient. Let's take it down another road. What if they're the type of patient that doesn't comply? What if they don't follow their weight-bearing status? What if they fall again? Lots of what ifs.